Hello friends, myself Dr. Harmeet Goel. I have done my MBBS from Lady Harding Medical College, Delhi and post-graduation in Ops and Gynae from VMMC and Safdarjung Hospital, Delhi. Then hospital management course from National Institute of Health and Family Welfare. I am an Ops Gynae faculty for the FMG as well as the PG coaching for last 17 years. And on the huge demand of my students, I have been teaching the classes in all over India and abroad on the huge demand of my students, and they wanted me to take up some important discussions on the online platform. In this regard, I have decided to take up some of the questions in my video. Also, I want to share the cover page of my book that is being very, very popular among FMG students with the name of the title of the book is The Rapid Revision of Obstetrics and Gynecology. This book I have written and this is the third edition. It is available on the Amazon and on the Pulse publication website. In this book, I have already written the questions as well as there is the text and theory discussion. There are tables, there are short forms, there are key points, there are images during the chapter itself and at the end of the textbook also. And this book contains questions of FMG exam starting from 2003 to the latest 2018. Okay, next edition is awaited. Till now this edition is going on. So I would like to talk about some of the important questions which has been asked in the last FMG exam December 2019. So here are some of the important discussions. First of all, I would like to mention some of the important topics which are the high yielding topics, the obstetrics topics which are very, very important. As I have been teaching in FMGE and NEET PG since last 17 years. So what I see, there is a change in the pattern of the exam of FMG also, and there is many questions which are being overlapping between FMG and NEET PG. If I talk about the Obs Gynae subject in FMGE exam, this has from the beginning one of the important clinical subjects which has helped many students to pass their exam. There are 300 questions which are being asked in MCI exam, including the paper 1 and paper 2. Now, out of 300, the weightage for Obs Gynae was supposed to be 30 questions out of 300. That means 10% of the total paper is Obs Gynae subject. But I have taken the reviews of the students in last exam, December 2019, and many of my students and students which I taught, maybe studying in various academies, they come to attend my Obs Gynae lectures when I take my individual class or I take a one-day revision class. So they have told me, many of them cleared their exam, that there were around 50 to 60 questions of Obs Gynae. That means 20% of the paper last time was Obs and Gynae exam. Okay, and the high yielding topics in this, let me talk about my subject. In my subsequent videos, I will be talking about some of the other subjects which is utmost important apart from the Obs Gynae subject. So I will be giving you idea about other subjects and how to crack. So I think many of you must have an idea, out of 300, you are supposed to score 150 marks. And many of my students have their full trust in Obs Gynae subject, as the content of the Obs Gynae subject is limited, as there is no super specialization. When you come to attend the subjects, like medicine and surgery subjects, which are very, very vast subject. And there is super specialization available on these subjects. Like in medicine, there is DM. In surgery, there is MCH. Okay. So the subject understanding and the questions, they become very, very vast. Okay. Wherein obs gynae, there is no super specialization as such, but there are fellowships available. Like IVF is very upcoming branch. Fetal medicine is again a very much upcoming branch, etc. Okay. So in this regard, the students of the FMGE as well as various PG, they have complete faith on this subject of obs and gynae, even if image-based questions are being asked. So in my teaching, what I do is, whenever I'm taking a class for FMG exam students, first of all, I discuss the theory part. Accordingly, I will tell them the FMG MCQs which has been asked in last 17 years with the topic itself. Okay. And I show them the images. I teach them the key points. I make tables and brief the content. Then I add some of the AIMS questions, NEET PG questions, UPSC exam questions. So whenever I take up the lecture, it is a complete discussion. So that is why majority of the students, they are able to clear their exam and they don't have any problem in solving the obs gynae subject. Now, this is just a brief idea which I just gave you what way I take my classes. Now, just to focus on the questions of FMG December 2019. Some of the questions I'm discussing here in this video, some of the questions and important topics I will be taking in my next videos. So in this, what I have seen, the topic of PPH, postpartum hemorrhage, acute inversion of uterus, topic of pregnancy-induced hypertension, including eclampsia, topic of antepartum hemorrhage, which includes placenta previa and abruptio placentae, topic of abortions, topic of normal labor, topic of twins, topic of fetal development, including the placenta, including the amniotic fluid, including the umbilical cord. So many of these topics which I've listed, these are the main topics where the questions are being asked, and the favorite is PPH, acute inversion, PIH, APH, abortions, twins, normal label. All these are the favorites. I'm not saying that other topics, they're not asking questions, but they're asking one question or the other question. Like sometimes they ask about diabetes. Now, so for last two exams, there has been a question on the topic of diabetes, like what is the cutoff value for glucose challenge test when you're doing screening of diabetes in the pregnant ladies, or according to the latest DIPSI criteria. Then what is the most common fetal complication that can occur in the baby born to diabetic mother, which is congenital heart disease. Then on the diagnosis of pregnancy, also there is a question, sometimes the signs of pregnancy. This time they have asked on the ultrasound double decidual sign. So there is definitely a question on the ultrasound from the obstetrics. Now, in gynecology, I'm not saying that students, you should leave the other topics in the obstetrics, that I did not say. I'm just saying these topics you should prepare at your utmost priority so that majority of the questions you are able to solve. In gynae, the most important topic has become for questions is the topic of contraception, where there were 7 questions in the last exam. Then the topic of menstrual disorders. where there were 5 to 6 questions in the previous exam. Then there was a topic of infertility, where there are 2 to 3 questions being asked from the topic of infertility. Then there is a topic, ectopic pregnancy, where at least 2 to 3 questions they have asked. And even there was an image-based questions last time on the topic of ectopic pregnancy. Then they have asked the question on the topic of endometriosis. At least 1 to 2 questions are being asked. Then there is a question from the topic of urinary fistulae. They have asked at least 1 to 2 questions. So these are some of the topics which I have just mentioned where they're asking questions. Sometimes they're asking questions from the topic of trophoblastic tumors, to differentiate between a complete mole or the partial mole, or they ask what is the tumor marker for choriocarcinoma, what is the most common site of metastasis of choriocarcinoma, that is the lungs, or they have asked in the PG style the karyotype of the complete mole which is diploid, and they have asked the abnormal chromosomes are maternal in origin or paternal in origin. When I take the lecture and I give the complete notes to the students, and many students they say, ma'am, from your notes many of our questions are being covered up, because as apart from the theory part, you are discussing the MCQs of the FMGE exam, UPSC exam, AIMS PG, NEET PG. With the same notes, many of the students are able to clear their gynae part in the various PG entrance exams also. Plus, there is an image-based questions which is being asked on the some of the diameter, some of the types of the placenta, which is a pattern of the AIMS or the NEET PG exam. So in my subsequent videos, I will be discussing most of it. Now, as far as the topic of cancers in gynae was concerned, there have been times in 2000 where they have asked around 6 to 8 questions from the topic of gynecology cancers. This time it is just a matter of chance, because they want you to work what are the problems or what are the cases that you see at the MBBS level when you are posted in the doctor, as a doctor in the hospital. So every patient you don't have to refer to the gynecologist. Eclampsia cases, APH cases, placenta previa cases, abortion cases, how you are going to manage. That's why the focus is on the clinical. So some of the questions I'm discussing it here because I did to specifically shoot for the FMG students because their exam is just approaching. Later on, for more topic discussions, I will be shooting more videos so that everybody of the students, they get benefited. It is not the FMG students that they are searching my lectures on the YouTube channel and all. It is the other PG students also, and keep on getting their calls on my WhatsApp, on my email ID. So that is why I decided. So I will bring not very, very long videos like 4 or 5 hours and all that. Small videos I will be releasing so that easier for you to learn from those videos. So the teaching experience, the knowledge is to deliver, and it should reach the majority of the students as long as possible and as long as I can deliver. So that is why I selected the online platform. So the first question I would like to discuss here is 2019 December FMG exam question. The question was, there is a pregnant lady and there is a history of 4 to 5 convulsions at home. When she came to the hospital, her BP was 180 by 120. Okay. What is your next line of management? What's your next line of management? Okay. So the options were, are you going to give labetalol? Are you going to give magnesium sulfate? Are you going to give labetalol plus magnesium sulfate? Or you are going to the conservative management? So in this question, as we have seen that the pregnant lady came with a history of convulsions at home, and when the BP is taken in the hospital, it is 180 by 120. So clearly this is a case of eclampsia, and the options given is what is the next line of management. That is, are you going to give labetalol, magnesium sulfate, labetalol plus magnesium sulfate, or conservative management? First thing is, in eclampsia case, there is no role of conservative management because we cannot wait for next bout of convulsions. Okay. So in this case, we have to do two things. Number one is to treat the convulsions. So in this regard, we have to give anticonvulsant, and anticonvulsant of choice in eclampsia is always the magnesium sulfate. And you have to reduce the blood pressure because she can have next bout of convulsion. So we have to give antihypertensive. An antihypertensive of choice in pregnancy nowadays is labetalol because it is quick in onset of action. So the correct answer to this question is labetalol plus magnesium sulfate both. Okay. So labetalol is the antihypertensive of choice in pregnancy, and magnesium sulfate is the anticonvulsant of choice in pregnancy. Now, many times a question is being asked, what is the antihypertensive of choice in hypertensive crisis in pregnancy? Hypertensive crisis in pregnancy. So friends, again the answer to this question is labetalol. Now why labetalol and what is labetalol? Labetalol is alpha plus beta blocker. It is alpha plus beta blocker, and it is onset of action is fast. Many years back, the sublingual nifedipine was given, but it is considered more dangerous as it is to cause sudden hypotension, which is not acceptable in PIH or eclampsia patient. Now, labetalol has emerged as a drug of choice because its onset of action is fast. There is no teratogenic effect, so it is very, very safe drug. Number two, it can be given in oral form or it can be given by intravenous infusion. Fine. Now, for the anticonvulsant, it is magnesium sulfate which is preferred, and magnesium sulfate we follow the loading dose, and then we have to give a maintenance therapy. In the loading dose, it is 14 gram of magnesium sulfate which is given, that is 4 gram 20% magnesium sulfate by intravenous route and 10 gram of 50% magnesium sulfate by intramuscular route. After that, there is a maintenance therapy. That means after 4 hours, you are supposed to check the knee jerk, respiratory rate, and urine output. Knee jerk should be present, respiratory rate should be normal, and urine output should be more than 100 ml in 4 hours or more than 30 ml in 1 hour. So if all these three parameters are all right, you are supposed to give maintenance dose. Maintenance dose includes 5 gram of 50% magnesium sulfate intramuscular in alternate buttocks. Okay. Till how long you will be giving? Till 24 hours of delivery or 24 hours of last convulsion. 24 hours of delivery or 24 hours of last convulsion. That is how the magnesium sulfate is being given. So very important point is whenever an eclampsia patient comes, apart from other management, catheterization of the patient is must. Why? Because you need to monitor the urine output. If after 4 hours there is no urine output, then you have to stop magnesium sulfate because toxicity can appear and you have to replace it with next line of anticonvulsant, that is injection phenytoin. Injection phenytoin. Now, there is another question which is very, very important. If a patient is coming up with eclampsia, and when she comes to you, she is unconscious and she is throwing fits. Now, my question is, what is the first line of management you are going to do? This is a PG question as well as important for NCI exam. What is the first line you are going to do? Are you going to give antihypertensive? Are you going to give magnesium sulfate? Or you will check the patency of the airway, or you will straight away going to take the patient for cesarean section. Well, when the patient is unconscious and she's throwing fits, the first line of management will not be antihypertensive, it will not be magnesium sulfate, it will not be cesarean section. These are important, but at a second step, because you will be loading the magnesium sulfate and your patient will be loaded from aspiration. Fine. So patency of the airway is the first step that is to be done. That means maintain the airway. What does it mean? That unconscious patient tongue can fall back and block the respiratory passages, or she can aspirate the secretions and die. So always remember ABC, which is very, very important. ABC means airway, breathing, and circulation. Airway, breathing, and circulation. Okay. Now, if I start taking a topic, then the whole point will be that I will keep on discussing one topic. So I will be sharing further videos for a topic discussion. Here I want to share some few questions of FMG exam. So I'm taking up a next important question of December 2019 FMG exam. And the question was that a lady has delivered the child and placenta has not delivered. If forcibly you try traction to deliver the placenta, what complication is likely to occur? So the lady has delivered the child and placenta has not delivered, and forcibly if you try the traction to deliver the placenta, what complication is likely to occur? So in this case, the complication that is likely to occur is acute inversion of uterus. If nowadays the WHO has given a guidelines for active management of third stage of labor, where they say after the delivery of the baby, you have to deliver the placenta by controlled cord traction method. Controlled cord traction method. And after the delivery of the baby, you have to give injection oxytocin intramuscular bolus. So this is the important steps in managing the case in the active management of third stage of labor. So if you forcibly try to extract the placenta, what will happen? There will be acute inversion of uterus that can occur. Okay. Similar question is been asked in the various PG exam also, and it can be expected as a question in 2020 FMG exam. May occur, may be asked in this format or may not be asked, that I can't say, but it's my duty to discuss it here, that a lady delivered a child. And she went into shock, which is out of proportion of blood loss, So what is the reason behind this, where the shock is out of proportion of blood loss? In this regard, they give an option like postpartum hemorrhage, number 2, acute inversion of uterus, number 3, amniotic fluid embolism, and fourth option can be anything like DIC, like fat embolism, anything. Okay. So when a question is writing like a lady delivered a child and went into shock, then the first thing that strikes your mind is PPH. But read the question very carefully. Here it is written that the shock is out of proportion of blood loss. That means blood loss has not taken so much, but she has gone into shock. So in this regard, it will be acute inversion of uterus. The most common cause for acute inversion of uterus is mismanaged third stage of labor. Mismanaged third stage of labor. Okay. So that is what is the cause for acute inversion. And there are two types of shock which can occur in this case. Number 1, it is hypovolumic shock because uterine surface is out. Number 2, it is neurogenic shock because the uterus is out, so the pedicles get stretched out. So that is what in this question they are trying to refer is the shock is out of proportion of blood loss. That means blood loss has not occurred so much, but the shock is very, very pronounced. That means it is a neurogenic shock. So in this case, no management should be done in the labor. So the management should be in the operation theater. So what you have to do is, you have to call for help and immediately start IV line and ringer lactate drip. Ringer lactate drip. The best fluid for management of shock is a ringer lactate. Then call the relative to take the consent, then arrange for blood transfusion. Arrange for blood transfusion. That means take a blood sample, label it with a serial number, patient's name, send it for blood group cross match, fill the blood requisition form, call the ward boy, send the blood sample and the form to the blood bank. They will cross match and they will make the blood available. Mind it, blood transfusion is not going to stop the bleeding. It is going to stop or replace the blood which patient is losing. Then inform the OT and shift the patient to operation theater. In the operation theater, you have to do manual reposition of uterus back into its anatomical position under general anesthesia. Manual reposition of uterus back into its anatomical position under general anesthesia, followed by uterotonics. What are uterotonics? Agents that contract the uterus. That is injection oxytocin, which is to be given in IV infusion. Then injection methergine intramuscularly, and if the need arises, prostaglandin F2 alpha injection intramuscular. So if you feel the patient has lost so much of blood, then you can give blood transfusion. Here, important step you have to notice is, after you have deposited the uterus back into its anatomical position, you have to tell the anesthetist to stop the general anesthesia, because it will cause more relaxation of uterus and further blood loss will occur. So after your maneuver is over to deposit the uterus, you ask the anesthetist to stop the general anesthesia, and now your aim should be to contract the uterus. So in this regard, you have to give uterotonics. If the need arises, you can give blood transfusion, otherwise you can skip out this step. Another important question which came in this exam of FMG was, there is a 36 weeks of pregnancy, a pregnant lady. Okay. She had fallen in the bathroom. Okay. Then she is complaining of pain, abdomen, and there is bleeding. When she comes to you, per abdomen, the uterus is tender. So what do you think is the diagnosis of this? There is history of fall, patient in the third trimester, that is 36 weeks. She has pain, bleeding, and tender uterus. I think that is a very, very simple question. Even you don't have to look at the other options. It is straight away a case of accidental hemorrhage or abruptio placenta. Accidental hemorrhage or abruptio placenta. Then there was a question whether you consider it to be in gynae or you consider it to be in obstetrics. They have asked a straight question. Most common cause for PID, that is pelvic inflammatory disease. They have given the option as gonococcus, chlamydia, mycoplasma, etc. And some of the students even mark this question as wrong. Thus, let me tell you, nowadays single liner questions are being asked at very, very less number, and whatever is being asked, you should be able to correct all of them. Like these are very, very straightforward questions. And as comparison in Obs Gynae, even if it is a clinical question, you are able to apply your logic and you can arrive at a correct answer. So friends, straight away, the answer to this question is chlamydia. No way you should mark gonorrhea as your answer. So overall, worldwide, the most common positive agent for PID is chlamydia. In India, it is tuberculosis. Now here itself, let me mention the drug of choice for chlamydia. Drug of choice for chlamydia is azithromycin, whereas drug of choice for gonococcal infection is ceftriaxone. Drug of choice for gonococcal infection is ceftriaxone. Okay. And remember, most common presentation of genital tuberculosis. Always remember, in the reproductive age group, the most common presentation of genital tuberculosis is always infertility. It is always infertility. Okay. And 90% cases of genital tuberculosis, the infection occurs in the fallopian tubes, leading to blockage and infertility. Now, there were two important questions being asked on the drugs, and it is important for me to conclude with these two drugs. Further questions, I will come up with more videos. There was a question being asked, and it is a PG level question which they have asked in MCI, that is anti-epileptic drug of choice in pregnancy with least teratogenic effect. The options are phenobarbital, number 2, carbamazepine, number 3, lamotrigine, number 4, levetiracetam. So let's take one after the other. Anti-epileptic drug they have asked with least teratogenic effect in pregnancy. When I was teaching in 2008, the answer was phenobarbital. Then few years later, it was changed to carbamazepine, and the science is a changing field every day. You know, like the things are being changing, fine. So as the answer to these latest questions. So lamotrigine was the answer till the last year, and even in my book of the previous edition, lamotrigine is the one which has been written. But latest, according to the PG entrance and everywhere, the answer has been changed to levetiracetam. So latest, friends, what answer you are supposed to mark is levetiracetam is the anti-epileptic drug with least teratogenic effect. This is an question like to be asked at AIMS PG level, but they have asked in MCI. Okay, so levetiracetam. The 2019 June MCI exam, they have asked what is a drug? Okay, what is a drug which has got maximum teratogenic effect, maximum teratogenic effect. So the answer is sodium valproate. Sodium valproate. Fine. Now another question on the drug. 2019 December FMG was, that's again a PG level question which they have asked in MCI. We can correlate because we are taking the classes in the PG as well as MCI. So many times the PG level questions we discuss in the MCI in just a flow, and many of the students get benefited because if by chance there is a change in the pattern, so they are able to mark the answers. Now, there was a new question being asked. What is the anti-thyroid drug of choice in pregnancy in the third trimester? Anti-thyroid drug in pregnancy in the third trimester. So, there is a confusion among the students that are they going to mark propyl thiouracil or they going to mark carbimazole. So majority of the students, they have marked propyl thiouracil, but let me mention propyl thiouracil is an anti-thyroid drug for the first trimester of pregnancy. Whereas they have asked the third trimester, so the answer is carbimazole, which is the anti-thyroid drug in the third trimester of pregnancy.